Such a common condition, vertigo. You need to understand that the little background about it, not too much. So we have the five senses you already know. There is a wonderful called sixth sense, which we do not really recognize. That is called the equilibrium. The balance or the equilibrium is the sixth sense we all have. This is also observed by the same nerve, auditory nerve, the vestibulocochlear nerve. The cochlear part is the audition. The vestibular part is the balance. So we generally don't notice that it is a special sense. So you can see the vestibular apparatus as you see here on the screen. It is the inner ear, basically. As you can see here, this is the vestibulocochlear nerve there, and it has got the two components, the vestibular component and the cochlear component. They're together joined to form the eighth nerve or the vestibulocochlear nerve, which goes in very close proximity to the seventh nerve or the facial nerve. So the blue part is the cochlear part and the brown part is the vestibular part. The blue and brown parts together is the vestibulocochlear, and there are ganglions inside the cochlea, and there are small recognized cells, otoliths, which are there in the labyrinth and the vestibule. Okay. So you can see here the semicircular shaped canals are there. These are called the semicircular canals. So there are three semicircular canals, the superior semicircular canal, anterior and the lateral semicircular canal. No organism has got such a wonderful arrangement of the semicircular canals. Man is having unstable equilibrium because his base is so small, the body weight and height is so high. For him to be stable, he requires every second to second, split second information about the position, which is grabbed by the semicircular canals, the position of the head, torso in relation to the ground or the seat is assessed every time, and then required postural adjustments is made so that the organism or the man is not thrown onto the ground and is stable while standing, walking, running, doing acrobatics, so many things you do. With very little support, they are doing balance also. All that is possible because of the vestibular apparatus. Okay. Now the semicircular canals, you see the lateral one, the superior one, and the posterior, not the anterior. The posterior semicircular canal is like this, the superior one is like this, and the lateral one is like this. One camera is like this, side to side movement. The posterior one is the one which senses this movement. The superior one is the one which senses this movement. There are three moments now. One moment is moment of head forward and backward. The sensor is the superior one. The one moment of the head is sideward, this way. That is by the posterior. And one moment is towards side of the body. That is the lateral. So these three together, they form one unit, and there is a vestibule and a saccule. A sac-like thing is called the saccule. Before that, there is a bulb-like thing called the vestibule. You can see the bulb and the sac. The bulb is called the vestibule. The sac is called the saccule. And you can see small black dots. These black dots are the loose particles are called otoliths. They have a lot to do in our understanding of vertigo. Okay. Now, as far as the cochlea is concerned, as far as the vestibule is concerned, there are otoconia and then the hair cells. What are otoconia and what are hair cells? Vestibular apparatus, utricle and the saccule. Utricle is the vestibule and the sac. It contains what are called otoconia. Otoconia is small microstones like things. And for linear movement, vestibular apparatus. The semicircular canals, they have a fluid called the endolymph. Liquid is there, minute micro quantities of liquid, and there are cilia also are there. So when the cilia move, they are sensors. These cilia, when they move, when the endolymph moves, the cilia move. Suppose this is the endolymph layer. The cilia are hanging in that. If there is a movement in the endolymph, the cilia move. When the cilia move, there is a reticular membrane and the cupola and the otoconia. It is transmitted to the nerve endings there. So you can see the static tilt and autolytic displacement. So whenever there is a movement of the semicircular canal, the stones are displaced. The stones move. When the stones move, there will be a sensation. The hair cells are triggered and the impulses are created. Endolymph and cilia, they register the head velocity. Normally, there are no otoliths in the semicircular canals. Only in the vestibule and the saccule, we contain the otoconia. For angular movement also, the semicircular canals are important. Okay. Vestibulo-optic tracts and vestibulospinal connections. Vestibulo-optic reticular connections, vertibulospino-reticular connections are the connections that we have. Okay. Now, to what parts of the brain this vestibule is connected? The semicircular canals and the vestibular apparatus is connected. One, of course, it is connected to the brainstem. Brainstem is one connection. Cerebellum is another connection. Oculomotor nerves and oculomotor muscles are another connection. Cortex is another connection. Spinal muscles. Because cerebellum also contains balance. So it controls balance. So whatever cerebellum has to know what is happening, what is the position of the semicircular canals and all. Brainstem has to be informed because it has to correlate with several nuclei in the brainstem concerning the posture of the head, posture of the neck, and spinal muscles are important. The lower limb muscles are important, and eye coordination is important. If you move the head this side, the eyes also should move. So oculomotor connections are important, and of course the cortical connections to control the overall picture. So this vestibulo-spino-reticular tracts, VSR. Vestibular pathways include brainstem, spinal muscles, cortical muscles, vestibulocochlear, vestibulobulbar. Vestibulobulbar is brainstem, vestibulocerebellar, vestibulo-optic, and vestibulospinal. These are the various tracts. Any derangement in any one of these things can result in imbalance or balance disorder. So now, equilibrium or balance is controlled by three mechanisms. One is the visual inputs, the second one is the vestibular inputs, the third one is the sensory. That is why when we close our eyes, we always find it difficult to make the balance. But still, in a moment's time, your vestibule and the sensory tracts will help you to retain the balance. That is why when you wanted to test the Romberg's test, what you will do, you ask the patient to close the eyes and also open the eyes, whether there is ataxia with closed eyes or open eyes. So that is again a test because you are cutting the visual impulses by closing the eyes. By asking him to stand and stretch his hands like this, you are testing the sensory tracts as well as the vestibular tract. So visual, vestibular, and sensory. These three result in what is called the spatial orientation of the head and neck in relation to the torso. Okay. There are three things that normally you see in clinical practice. One is called syncope, the other is called vertigo, the other is called gait ataxia. These are three entirely different things due to different mechanisms. That syncope we already covered. I think we have completed syncope, and now we are vertigo we are doing. Gait ataxia is a sensory problem. Syncope is more a cardiac, neurogenic or cardiovascular, neurogenic and other causes of syncope. Vertigo may be ocular, may be neural. We will see that gait ataxia is mostly sensory ataxia. So because when the sensory inputs are not going, the proprioceptive impulses from the lower limbs and the feet they reach through the spinal columns, posterior spinal columns, gall and Broda tracts, the posterior column sensations, go to the brain and then inform the brain about the position and of the feet. And that's so much so ataxia is not there. Okay. So what is vertigo? What are the symptoms of vertigo? Dizziness. People call it as, some people in India here, we call it as giddiness. But nobody understands giddiness in Western world. They call it as dizziness. Both mean the same. Indian equivalent of dizziness. It's a subjective term. And some people, if they feel slightly like this, they call dizzy. Some people are thrown onto the ground only, they say it is dizzy. So it is not very clear from the patient's description. You need to ask the patient. Interchangeably used for many other symptoms. Suppose they feel hypoglycemic and feel that they're falling down, they call it as giddy. And they have a syncope, they call it as giddy. Sensation of movement, spinning and revolving, swaying, unsteadiness, push to the side. So you ask the patient, do you feel any movement of the surroundings or movement of you with respect to them? Subjective vertigo, objective vertigo. Objective vertigo means surrounding things are moving relative to him. Subjective vertigo means he is stable, the surroundings are fixed, but he feels rotating in that. So this you experience, particularly when you go around and children, go round and round and round. After 1-2 minutes, they'll feel very giddy. That is a subjective vertigo they feel. Spinning and revolving. Spinning means like this, revolving means like. Spinning means within like that, revolving is going left. Swaying, this side and that side, and then unsteadiness, and as though pushed to one side. 10% of the adults above have vestibular problem. What is the frequency of hypertension? The prevalence of hypertension is 4 to 5% in adults. The frequency of balance problem is 10%. It is more common than even hypertension and diabetes. But hypertension and diabetes have a lot of target organ damage and they are killer diseases. Vestibular symptoms are not that pathologically bad unless it is a brainstem lesion or something. Mild uneasiness to severe balance problems. Please take these symptoms very seriously. Why? Sometimes these symptoms may be an indicator of brainstem tumor, may be an indicator of cerebral cortical involvement, may be an indicator of cerebellar disease. It is not simply not to brush away. So you have to take these symptoms very clearly and very carefully. What is physiological vertigo? Physiologically also, everyone else feel you get. Supposing you are going on a merry-go-round, what will happen? You feel it. Giant wheel rides, you feel vertigo. Unfamiliar head movements. You go in a ship, everybody feels vertigo because the seesaw movements there in the sea waves produce vertigo. This is called seasickness. And mismatch of these systems balance can occur in unfamiliar head movements, seasickness, merry-go-rounds, giant wheel rides, unusual head and neck positions. Supposing you are asked to look at the astronomic parade in the sky, every day it is going on. So you want to look, is it Mars? Is it this? Is it Venus? You go on stretching your neck backward and backward while walking, and you feel it. Unusual neck movements, or somebody is painting a ceiling, or somebody is trying to hang something to the ceiling by looking at like that while standing, and they may feel vertigo. Space sickness is another entity called zero gravity environment. Once you cross the stratosphere, that is where the atmosphere is surrounded by the air. Once you cross the zone of that atmosphere and the air column there, then you enter into an orbit called zero gravity orbit. There you don't feel the weight at all. So the planes are still in that orbit. That is where they are pulled down when they wanted to land, they can land. Whereas when you fly higher than the Earth's atmosphere, then you feel the space sickness. Optical illusions. For example, you sit in a train and keep on watching. The objects are very fast moving. Then you feel sometimes giddy. Or you are given a spinning wheel colored wheel and you ask to look at the colored wheel, then the colored wheel goes faster and you feel giddy. So pre-syncope or lightheadedness is not vertigo. Before syncope, we will have some sort of premonitory symptoms that is called pre-syncope. That is not vertigo. So what are the causes of vertigo? Autological, neurological, medical, and of course psychogenic. 40 to 50% of the vertigo is due to autological causes. And the physician is the one who has to diagnose. The ENT person examines the ear and vestibule, but you have to guide him that he has to undergo autological evaluation. So 40 to 50% are autologic, neurological 10 to 20%, medical causes are 10 to 25, psychological causes are 15 to 30%. So what are the autological causes of vertigo? Now, is it symmetric vertigo or asymmetric vertigo? Does he feel on one side this way or both sides? So vestibular neuronitis, asymmetric vertigo. Meniere's disease is an asymmetric vertigo. Vestibular neuronitis usually affects one ear more than the other ear. So viral infection of the vestibule can produce vestibular neuronitis, dizziness, vomiting, vertigo, and then hearing loss. All can occur. Meniere's disease. Meniere's disease, Symmetric. Symmetric means there are autotoxins like gentamicin, particularly any aminoglycoside, kanamycin, gentamicin, netilmycin, particularly gentamicin, can produce autotoxicity. Streptomycin, particularly, we are not using nowadays. In our days, when we were students, streptomycin vestibular damage and aortic damage is very high in those cases. Whenever we treat the patients, around 5 to 10% of people, they end up with deafness because of streptomycin, giddiness and streptomycin deafness. So we have to be very careful about such autotoxic drugs. Bilateral forms of vestibular neuronitis, if it occurs on both sides simultaneously, viral infection, it can produce symmetric and cross-coupling. Cross-coupling is a fistula and SCD. That we will see what is SCD. And then benign paroxysmal vertigo. The commonest cause of vertigo is BPPV, benign paroxysmal postural vertigo. The commonest cause of it. You should know how to evaluate and also treat BPPV. Okay. SCD is superior canal dehiscence. When the superior canal suddenly gives way, breaks, then it is an emergency. It produces sudden this one. Perilymphatic fistula. There will be the perilymph will leak there, and you can see the superior canal, the lateral canal, and the posterior canal. This is the posterior canal, the lateral canal, and the superior canal. How many we have? 3 computers on this side, 3 on this side. Total 6 computers are working. 2 superior ones are about this movement, 2 lateral ones are about side to side movement, and the posterior ones are about the head position in relation to the shoulder. So an opening in the round window allows perilymph to leak into the middle ear. This is the round window. And then when the opening is there, suppose it opens, if the middle ear cavity is this one, into the middle ear cavity, the perilymph drains. That is perilymphatic fistula, perilymph fistula. In most cases, there is a small oozing of fluid between the perilymphatic space and the air-filled middle ear. You can see those drops coming up there. This is the air-filled middle ear, and there is the perilymphatic drops are oozing out. This is the bone there, the temporal bone in which everything is housed there. Nicely, this is the drum membrane. This is the incus, malleus, and the stapes. Stapes is the foot process of the stapes. This is the stapes bone, the foot process, and the stirrup there. Okay. So this is about the acid. Then neurologic vertigo, vertebrobasilar insufficiency and stroke. Vertebrobasilar insufficiency. 2 vertebral arteries go and join to form one basilar artery. They supply the posterior inferior part of the cerebellum, posterior inferior cerebellar artery, and then the superior cerebellar artery, and the middle cerebellar artery. They supply the cerebellum. You must know the anatomy of the vertebrobasilar system. If you know that Wallenberg syndrome or vertebrobasilar insufficiency is a common cause of stroke and vertigo. Most common neurological vertigo is VBI. Migraine, about 10% of the central vertigo is migraine, typically associated with unilateral or bilateral vertigo. Aura of the migraine will be there, post-migraine deficiencies will be there, paralytic effects may remain, multisensory disequilibrium. Multisensory disequilibrium means the pain and touch sensations are affected, the posterior column sensations are affected, and all the system sensations are affected. Patients will have ataxia due to peripheral neuritis and also spinal cord tract diseases. Cervical vertigo. What happens if a patient comes with vertigo? Immediately you will think you will have cervical spondylosis. Let me take an X-ray cervical spine. What do? Patient comes with this one. You ask for X-ray cervical spine, which is not a common. Cervical vertigo, as far as the neurological vertigo is concerned, it is common. But overall vertigo, the BPPV is the most common thing. You should not miss BPPV thinking that it is cervical vertigo, giving some collar or low pressure CSF syndrome. That is post LP. Lumbar puncture is done, the leak is there, or the fluid is drained fast, 10 to 15 ml is removed, and the post lumbar puncture. Or there could be a CSF leak due to various reasons. CSF rhinorrhea, CSF autoria, CSF leaking into some space there. So, what are the neurological causes of vertigo? Before that, what are the autological causes? Autological causes are symmetric, asymmetric, cross-coupling. Vestibular neuronitis, Meniere's, autotoxins, bilateral vestibular neuronitis. BPPV is the commonest. The fistula of the vestibule, and then the superior canal dehiscence of the causes there. When you come to the neurological causes, VBI and stroke, most common neurological vertigo, migraine, and multisensory disequilibrium, cervical vertigo, low pressure CSF syndromes. Out of these, cervical vertigo is often thought of, and people are evaluated for cervical spondylosis, thinking that that is the cause. If you take an X-ray of a cervical spine above 45 years, mostly there will be some changes. That may not be the cause of the vertigo. The cause of the vertigo may be something different. General medical causes. What are the general medical causes? Cardiovascular, high blood pressure, arrhythmias, syncope, and OHTs, over the counter drugs that orthostatic hypotension. OHT is orthostatic hypotension. Okay, that is postural hypotension. Hypoglycemia due to diabetes or insulin use, medications, antihypertensive medications, vasodilator medications, infections like pneumonia, UTI, acute suppurative otitis media, chronic suppurative otitis media, B12 deficiency. It can cause subacute combined degeneration. That is, both the motor tract as well as the posterior columns are degenerating. It's a combined degeneration. It produces ataxia. So general causes are cardiovascular, hypoglycemia, medications, infections, B12 deficiency. Though it is a neurological disease, it's a general cause. The B12 deficiency is the cause. Undiagnosed, we said autological, neurological, medical, and undiagnosed. Undiagnosed psychogenic causes, somatization disorder, panic attacks, general anxiety, general anxiety disease, and then depression, hyperventilation syndromes, variety of anxiety states, unknown causes, not identifiable nor worked up. If nobody undergoes investigation, it will become unknown only. So, psychogenic, hyperventilation, unknown causes. So, these are the questions. Approach to that. How do you do? First, everyone should have this questionnaire should be there with you on your table. Do you feel unsteady while standing or walking? First question is, while standing or walking, is the giddiness or dizziness increasing? Do you feel if the room is spinning around you? Do you feel as if you are moving when you are standing or sitting still? Is sitting but feel some movement. Do you lose your balance and fall? Do you feel as if you are falling, as though you are falling? Do you feel as if you might faint? Some people call it as lightheadedness. Do you feel that your vision becomes blurred at that time? Do you feel disoriented? That is not knowing what is happening, who is there, what time of the day, disorientation, lose your sense of time, place, and identity. So these are some of the important questions. Do you feel unsteady while standing or walking? Do you feel as though the room is spinning? Do you feel movement while you are still sitting and standing, and is your balance lost and you fall? Do you feel you are falling? Do you feel as though you might faint? That means you may lose consciousness temporarily. Do you feel that your vision is blurred, and do you feel you are disoriented? Any one of these questions should be given importance. Now, how do I differentiate? The differential diagnosis is based on the duration of the vertigo. Very easy to differentiate, but provided you pay attention. How much time do you feel the kid? Just I'll have, sir, for 10-15 seconds, then I am all right. BPP. So patient suddenly he is getting up from bed and he feels dizzy, he sits, waits, vertigo is gone. That is BPPV, benign positional paroxysmal vertigo. Transient ischemic attacks and vertebral basilar insufficiency, 5 minutes, 10 minutes, 15 minutes, because it is a vascular event. They will have a prolonged Meniere's disease, hours together they will have vertigo. Oh, they will have whole day, morning to evening. The Meniere's fellow will have vertigo. Vestibular neuronitis for 1 week, 5 days, 7 days. He needs hospitalization. Vestibular neuronitis. Cervical vertigo. Months together he will be having the vertigo. Ototoxins, years together. So the duration itself speaks the diagnosis. Very transient vertigo, BPPV, minutes vertigo, VBI, Meniere's, hours vertigo, neuronitis, vestibular neuronitis, days, cervical vertigo, many months, ototoxins for years. Okay, based on the duration. Now, based on the onset also, this is called vertigo sieve. Sieve means what? You know what is sieving? Take something and the flour, you want to do something, the final powder comes down, all the coarse materials will remain. There is a sort of membrane, I don't know what you call, particularly rice flour, wheat flour use. So likewise, you have to sieve the symptoms, you sieve them and put them into different categories: onset, duration, associate. There are 3 sieves are used. What is the onset? Instantaneous, acute, slow, paroxysmal. Paroxysmal means comes and goes. Is it instantaneous? Is it acute? Is it slow? Is it paroxysmal? Instantaneous, 30 to 60 seconds. Acute, minutes to hours. Slow, days to months. Paroxysmal, the duration will be there as long as the paroxysm loss. Then, is there an associated tinnitus, associated loss of hearing, other neurological findings, other serious findings? So you have to see the vertigo based on the onset, duration, and association. Instantaneous vertigo, acute vertigo, slow, paroxysmal. 30 to 60 seconds, few minutes to hours, days and months, continuous. Tinnitus associated loss of hearing, CNS finding, serious disease. These will tell you tinnitus associated and loss of hearing will tell you probably it is Meniere's disease. Associated CNS finding, VVI, cervical or sensory tract disease or cervical vertigo. Serious diseases like ectopics, like the arrhythmias, hypotension, OHT, orthostatic hypotension. Now, clues in the history for the differential diagnosis. You're all still in the history. BPPV, benign paroxysmal positional vertigo, episodic vertigo, true vertigo, for seconds it lasts. It is episodic, paroxysmal, short duration, few seconds, associated with head and body position change. Patient says, I'm all right, sir, when I'm sitting still. But when I'm lying down and coming into the normal position, or from sitting and trying to lie down, the change of position of the head decides the vertigo, and it is short-lived, and it occurs in paroxysms. Most common form of vertigo is BPPV. Inner ear disease, sudden onset, vivid memory of vertigo. He says, I was all right at this point, and suddenly, like a stroke, it came. I am not able to have my balance. He clearly pinpoints. Up to 9:15, I played. By 9:20, I had severe vertigo. I was working in the office. I was there until 1 o'clock. I am all right. 1:05. Such a sharp memory will tell you it is an inner ear disease associated with hearing loss, ear pressure, tinnitus also may be there. Meniere's disease, vertigo loss for hours or days. CNS or cardiac or systemic disease, gradual in onset, ill-defined symptoms, multiple signs will be there. Cerebrovascular disease, sudden in onset, associated neurological deficit, and cerebrovascular risk factors like hypertension, diabetes, dyslipidemia, all these things will be there. Okay. Loosen the history. Some more central vertigo, brainstem disease, diplopia may be there. Patient complains of diplopia and vertigo, you are in at brainstem. Autonomic symptoms, nausea, dysarthria, dysphagia, facial weakness, unable to walk, ambulate. That means there is involvement of the brainstem nuclei, cranial nerve nuclei. That's why he has got diplopia, dysphagia, dysarthria, facial focal weakness, unable to ambulate, and then autonomic symptoms may be there. Cerebellar disease, he has ataxia, dysdiadochokinesis, and other cerebellar signs like hypotonia, pendular knee jerk, nystagmus, and all those cerebellar signs attached. Meniere's disease, hearing loss is the most important component. Ear pressure, tinnitus, and progressive. Progressive disease, tinnitus, hearing loss, pressure sensation in the ear, and long-standing vertigo. Months or days or months is Meniere's. Vestibular neuronitis, upper respiratory tract infection will be there. They will have it through the eustachian tube. It enters the vestibule and then produces vestibular neuronitis. Sensory changes may be there in C2 and C3, and it recovers faster. Sometimes the vestibular function may recover, but the auditory function will remain permanently impaired. We have many patients who had vestibular neuronitis, and then they will recover their balance part after 1 week or 10 days, but the damage to the hearing nerve part, that is the auditory part, will be there. They will have more or less some amount of deafness left in them. Migraine headache associated with dizziness, cerebrovascular disease, sudden onset, neurological disease, and cerebrovascular risk factors. So clinical findings. Differential diagnosis of central from peripheral vertigo is very important because central vertigo is serious, peripheral vertigo is from the peripheral organ, central vertigo is from the brainstem and the other connections, cerebellum, brainstem. So what you have to do is nystagmus should be looked at. There is a tool called the electronystagmogram. Just earlier days we used to examine teeth. Now electronystagmogram is there. Spontaneous nystagmus or gauge-induced nystagmus or positional nystagmus. Associated nausea, autonomic symptoms, horizontal nystagmus, vertical nystagmus, rotatory nystagmus. Horizontal nystagmus, vertical nystagmus, rotatory nystagmus. There may be latency in the onset of nystagmus. Failure of fixation suppression. FFS is called failure of fixation suppression. Fatigability by repeated testing has to be seen. Caloric testing. Another important test is caloric test. How do I do that? 1 ml of water is injected 30 to 40 degrees in each ear. 37 is the body temperature. Cold calorie test, hot calorie test. Cold calorie test is 30 degrees. Cold calorie should not inject a 5 degree water or ice water. Hot means not boiling water. But only 7 degrees this way or that. That body can recognize. 30 degrees cold and 44 degrees warm water. This is given for 1 ml is injected into each ear separately. Observe for the nystagmus using Frenzel's glasses. Okay. Here, cold, the nystagmus will go to the opposite side. Warm, same side. Cows, COWS. Cold, nystagmus to the opposite side. Warm, nystagmus to the same side. In vestibular paralysis, caloric testing will be negative. You inject cold to this one, you expect nystagmus, doesn't occur. That means there is a vestibular paralysis on this peripheral paralysis. Likewise, hot inject, it should move to the same side. It's not moving. Caloric test positive, normal. Caloric test negative, it's not there. It means pathological. Normally, there will be calorie test positive will be there because your vestibule should respond to the heat. Like the heat means not great heat, 7 degrees this way or that way. So, first assessment will be all the clinical information we have to see and differentiate peripheral from the central. And how do we do? Nystagmus and calorie testing. Nystagmus, is it spontaneous? Is it gauge induced? Gauge induced means when you ask him to look at a particular side only, it is getting. Or is it positional? That means when he's lying down or sitting or standing in which particular position. Is it associated with nausea, autonomic symptoms? Is it horizontal? Is it vertical? Or is it rotatory? Is it failure of fixation suppression and fatigability? Nystagmus is one thing which fatigues after repeated testing. So you ask the patient to look at this. After 4-5 times, you ask him, nystagmus will disappear. Because fatigability of the nystagmus. Caloric testing, 1 ml of water is injected into the external ear canal, 30 degrees for cold, 44 degrees for the hot. Observe for the nystagmus. Mild nystagmus will be there. You require Frenzel's glasses to observe. COWS, CO cold is opposite side, warm is same side. What is the nystagmus? What is the nystagmus is involuntary rhythmic oscillation of the eyes. There will be a jerky fast phase followed by a slow return to the starting position. Jerky fast phase and slow return to the central phase. The direction is to the fast phase. Which side is the fast phase? That is the direction. Nystagmus to the right. Nystagmus to the left. Okay. Nystagmogram accurately records horizontal, vertical, torsional or rotatory types 10 to 40 seconds after the head movement. Fatigability indicates peripheral cause. If the nystagmus is getting fatigued, it is not central nystagmus, it is peripheral nystagmus. You can see here, these are called the Frenzel's lenses. What you have to do is just wear the lenses like that. And there is a recorder there, and it records the computerized electron nystagmogram is there, and then it will record the movement of the eye nystagmus precisely in the video camera there that is attached to the Frenzel's lenses. And you know whether the direction of the first phase is the direction of the nystagmus. When you say clinical presentation on a case sheet, nystagmus to the right means the fast phase is to the right. Nystagmus to the left, fast phase is to the left. Nystagmus upward means fast phase is to the upward, like that. Okay, these are Frenzel's lenses. Now, clinical findings, continued vestibulospinal reflex, that is called VSR, tandem gait. What is tandem gait? Tandem gait is asking the patient to walk on a straight line. You know the tandem gait test? 1 foot before the other foot. Okay, Romberg's test. This is test of equilibrium and proprioception. So what you do is in Romberg's test, you ask the patient to keep both the feet together, the medial malleoli touching each other, like that. And then he is placing the foot firmly and keep his hand on the side to start with. Then he will bring the hands to the front like that and then wait for a few seconds. Then ask him to close the eyes. Okay? Giddiness with open eyes, dizziness or vertigo with closed eyes. Normally, what will happen if the sensory tracts are not working? It is a sensory ataxia. It is compensated by the eyesight. Okay, so once you close the eyes, it will become more. That means it is sensory ataxia. Sensory attack, this will be definitely asked in your exams. How do you differentiate sensory from cerebellar, from vestibular by doing a Romberg's test? Romberg's test is ask the patient to stand erect without any support, both feet together, with the hands on the side. Wait for 15 seconds. Then hands will come outstretched to the front. He will be looking forward. Okay. Then what you do is you see whether he is unstable. If he is unstable with eyes open, there is no reason to cause him to close the eyes. He will fall. So first of all, if he is stable with eyes open, okay, then close the eyes. Giddiness has precipitated. That means sensory ataxia. The sensory tracts are not working. Hitherto is compensating with the visual information. Visual information, you have cut off sensory information. Okay. Giddiness with eyes open is due to the vestibular cause. Giddiness due to eyes closed is sensory causes. Giddiness eyes closed or open is cerebral. Cerebellar ataxia will be there. Open or closed doesn't discriminate. Either open or closed, it is open eyes, it is the vestibular, and then closed eyes, sensory tract. That's all. So you see, this is tandem gait, Romberg test are very important tests. Pakuda stepping test. What do you do is, 5 meters, 0.5 meters, or 30 degrees stepping and coming down. 30 degrees step up and then step down, step up, step down. It should not produce giddiness in a normal individual. Hammett vestibular stress test. Just like cardiac stress test, you have got Hammett's vestibular stress test. Sensory component, motor component, body impulse test, and then hyperventilation test. These are some of the clinical tests. Vestibulospinal reflex test, tandem gait, Romberg, Pakuda. Hammett vestibular stress test and hyperventilation. Routine test protocols. What are the tests I should order the patient coming with vertigo? Thorough clinical examination for central causes, clinical test of balance as described before, complete neurological examination, TBC and ESR, ECG with a rhythm strip, CV risk factor assessment, cervical spine evaluation, pure tone audiometry, calorie test and other vertigo factors. MRI and MRA vertebrovascular territory depending on your conclusion. If you feel the brainstem or the CNS is involved, then you may require an MRI and MRA and the vertebrovascular territory you need to evaluate. Otherwise, routinely, MRI and MRA are not indicated. What are the vestibular tests? ENG, electronystagmogram using the fragile lenses. OKN, optokinetic nystagmus, saccadic test, gauge test, pursuit eye movement test, bithermal calorie test, I told you, positioning test, Dix Hallpike, this I will show you. This, every one of you should know, Dix Hallpike's positioning test. This is for the BPPV. And computerized dynamic postulography and then rotating chair test. This is for sinusoidal horn of the sinusoidal horn accentuation. That is not commonly done. Okay. Now you see oscillopsia. What is oscillopsia? Oscillopsia means the objects will be oscillating. Because the eyes are oscillating. And then opsia is eye, oscillopsia. And then rotatory chair test, You ask the patient to sit in a chair and the chair rotates. After rotation, everyone feels giddy, but then the duration within which it settles down will be different from a pathological person from a physiological this one. Now, four main categories of balance disorders: vertigo, syncope, ataxia, psychogenic. Psychogenic is 10%, ataxia is 15%, syncope is 25%, and 50% is vertigo. Out of them, 40% of that 50%, that is around 20% of that, is BPPV. So, if it is vertigo, is it central or peripheral? First question is it a central vertigo, peripheral? Peripheral vertigo means hand organ damage. Central vertigo means brainstem causes, other neurological causes, cardiovascular causes, general medical causes. Causes of peripheral vertigo. What are the causes of peripheral vertigo? BPPV stands out among all the other. BPPV is very important. Vestibular neuronitis, labyrinthitis, ototoxins, autoimmune disease, Meniere's disease. So these are the peripheral vertigo causes. So write short notes on peripheral vertigo. Means you should bring about BPPV, Meniere's, autoimmune, ototoxins, labyrinthitis, and vestibular neuronitis. How do I differentiate the most common peripheral vertigo, which is the BPPV, from the central vertigo? BPPV is peripheral vertigo, commonest. Central vertigo, how do I do? Type of nystagmus. In BPPV is rotatory. In central, it is vertical or horizontal. Latency 30 to 40 seconds it takes. Central is immediately it will come. Fatigability is there in peripheral vertigo. Central vertigo, no fatigability. Habituation is there in peripheral vertigo. It is not there in central vertigo. Intensity very severe in BPPV and then very mild in central vertigo. Reproducibility variable, reproducibility very good. The vestibulo-ocular reflexes, positional vertigo, variable in BPPV, positional and hyperactive. VSR, vestibulospinal reflex, and gait, cautious gait. Patient walks with caution, whereas in the ataxic gait, they'll have wide-based gait. Neurological findings here, decreased hearing and tinnitus may be there or may not be there. Their brainstem disease and CNS may be there. This table differentiates the central from the peripheral vertigo. Benign paroxysmal positional vertigo. This is the commonest form of vertigo. You must know this very clearly. Episodic vertigo may occur with head movements, rolling over in bed, lying down, sitting up, leaning forward, turning the head in the horizontal. So if whenever he changes the position of the head in the bed from lying down to sitting, sitting or leaning forward or turning in the head in the bed and horizontal, symptoms of BPPV are worse always in the morning. Nausea is typically present. There is no vomiting. Head trauma may be there. Episodes of vertigo in BPPV in the last few seconds, they only last for a few seconds. Vestibular neuronitis and labyrinthitis, the vertigo lasts for hours or days. Pathology of BPPV. How does BPPV occur? There is calcium carbonate particles. These are called the otoconia or the otoliths, small stones like thing. They are normally attached to the hair cells on the membrane inside the utricle and the saccule, and they have no business to come into the semicircular canal. They are in the utricle and the saccule. They are tiny hair cell. The hair cell is attached to an otolith. So whenever the perilymph moves there, the otoliths move and then the hair cells move and trigger the electrical impulse. This happens in the utricle and the saccule. Utricle is connected to the three semicircular canals. Otoliths may become displaced from the utricle due to aging, due to head trauma, due to labyrinthine disease, and the otoliths now enter the semicircular canal. And there are hair cells in the semicircular canal. They stimulate the hair cells in the canals and then they cause the vertigo. Usually, the posterior canal is like this, horizontal. Lateral canal is like this, superior canal is like this. Otoliths cannot go up the posterior canal, they easily enter into the posterior canal. So the BPPV mechanism, you see, this is the saccule and the utricle there, and then the patient goes into a different position. The otoliths are displaced and they come. See, these are the otoliths, they're the white ones. When the patient goes 0 degrees, there's no the displaced otoliths from here to that. And again, I'll show you that one more time. You see here, otoliths are below here, and then now the position changes. The otoliths enter the posterior canal, they're displaced. They stimulate the hair cells there. So this is the otolith movement or the otoconia movement. Okay, Dick-Hallpike's test. This is very important for BPPV. First, warn the patient about the symptoms of vertigo. Patient is seated close to the end of the couch. The end of the couch, he sits here at the end of the couch. Patient's eyes must open to observe the nystagmus. You close his eyes like this, and you are looking for nystagmus. You cannot look for nystagmus. So what I do, I stand by the side of the patient. Patient is brought, seat is not here. His seat is brought almost close to the end of the table. And then he has to lay down outside the table. That's why there. And then eyes open. And tell him, he may feel giddy. I am here, I will hold, don't worry. Patient's eyes must be open and turn the patient's head to the left. 45 degrees to the left first. With your hands on either side of the patient's head, lay the patient down rapidly until the head is dependent and hanging from the couch. I will show you the maneuvers there. Check for vertigo. Nystagmus, fast phase of the nystagmus should be upbeat towards the forehead and ipsilateral towards the left. Bring the patient to the upright position. Nystagmus may be observed in the opposite direction. We will see step by step. So that is the first step. Make the patient sit like that, a little closer to the end of the table. Please maneuver step 1. Okay, so patient is seated like that. Watch this. Okay, now then what you do next one? Turn the patient to the left side while sitting on to his left side. That's step 2. And then lower his head below the couch. Watch this. Hello. So the patient is seated like that, a little closer to the end of the table so that the head will be hanging out when we test it. First, what you do, turn the patient head to the left side with your both the hands supported after warning the patient. Then bring the patient's head to the down position and the left side and observe for the nystagmus. Very rapidly you have. And then hold the head in that position with your both hands. Support the head and look for nystagmus. Patient should open the eyes. Then you turn him to the opposite side, to the right side, in the same position. Then what you do? Fully you ask him to tilt to the other side. The body also has tilted. That is step 6. Then the step 7, even further down, he should face facing down, he will go. After that, he will be in that position for a few seconds. Then you will hold the head like that, ask him to get up and sit, and then he is sitting and you are observing. Okay? And he bends that slightly forward and waits for you. That's the last step. Video also I will. So this Epilys test, positive means benign positional vertigo. Why? Because of the otoliths. Okay? So otoliths are shifted from this one. And these shifted otoliths will enter into the semicircular canal and produce sudden vertigo and nystagmus. So you have the Epilys maneuver and then the Hallpike's test. Hallpike's is the test, Epilys is the treatment. Treatment means when you do the Hallpike's test is positive, same thing you give him the treatment. So ask him to do this repeatedly and he gets used to it. And then with this treatment, he will become better. Treatment depends upon the cause identified, Brandon-Doff's exercises for BPPV, Meniere's disease, restriction of salt and fluid, diuretics, acetazolamide, for migraine prophylaxis with flunarizine, drug treatment to control acute attacks, steroids for labyrinthitis, stop ototoxic drugs, post-life hypotension, and then transtemporal labyrinthectomy and refractory Meniere's disease, and then the vestibular rehabilitation exercises. Transtemporal gentamicin injection. What we do is to paralyze the vestibular apparatus. In Meniere's disease, you deliberately inject the gentamicin through the temporal route, and the gentamicin, is toxic. That side is vestibule is paralyzed. There's no more giddiness, no more hearing also, but the symptoms are reduced. Okay. Brandon Dorff's exercises: sit on the edge of the bed near the middle with legs hanging down. Turn the head 45 degrees to the right side. Quickly lie down onto the left with the head still turned. Touch the bed with the portion of the head behind the ear. Maintain this position, every subsequent position, for 30 seconds. Sit up. Quickly lay down to the right side. After turning the head 45 to the left side, sit up. Do 6 to 10 repetitions every time. Epilepsy is what you do. Brandon Doss is what the patient does at home. Yeah, I advise this patient. Patient's nose should always point towards the ceiling. Okay. Pharmacological treatment. What are the drugs that I can use for treatment of vertigo? Here you have only 1 or 2 drugs in your hand. Always, sineragine and beta-histine. These are not approved for vertigo. US FDA does not approve sineragine and beta-histine for vertigo. They are vestibular sedatives. Okay. Antiemetics and anticholinergics. Meclizine is available as antivertic. Drug of choice is meclizine. Benzodiazepines, lorazepam, clonazepam, next best drug. Antihistaminics, promethazine, very effective. Vertigo. Antiemetics like dimenhydrine, dramamine, very effective. Anticholinergics, scopolamine topical patches can be there. In this country, we use sineragine, available as Tugeron, and a beta-histine, histidine, available as Vertin. We use very much, but FDA has not approved these drugs for vertigo. They are used in that country. They give meclizine, they give lorazepam or clonazepam, promethazine, dimenhydrine, or scopolamine. Autotoxic drugs. Short notes on autotoxic drugs. Gentamicin, amikacin, netilmicin, kanamycin, streptomycin. Quinine and its derivatives in chloroquine also may be autotoxic. Furosemide, very important class, is an autotoxic drug. Bumetanide, that's also congener, and ethacranic acid. These are the diuretics. Anti-cancer drugs like ciprofloxacin, cisplatin, vincristine. Aspirin and NSAIDs rarely can cause autotoxic ear drops like gentamicin, polymyxin, and colistin also will be a autotoxic drugs. That ends the story of vertigo.